All right, welcome everyone. We'll be starting on time. I'm Young Chae, Vice Chair of the Early Therapeutics and Rare Cancer Committee. Appreciate you all coming here to hear updates from our committee. Dr. Kurdrag is not here in person, but she'll be participating through virtual platform. You probably got email with the link, so you can also attend this meeting virtually and also send any questions through the chat box. I'll be able to see it and we'll address it at the end of each session. But if we're running out of time, we can address those questions at the very end. So we'll begin our meeting with Dr. Lara Davis. She is the Associate Professor at the Knight Cancer Institute, Oregon Health and Science University. She is the co-leader of the Translational Oncology Program, as well as the Sarcoma Disease Site Leader. She is also our leader of the Sarcoma Working Group. So she'll give us update on the Sarcoma Working Group.
Good morning, everybody. Good to see some people here in person, and I suspect more. Oh, look at that. Yes. All right, so I am the chair of the Sarcoma Working Group within this Early Therapeutics and Rare Cancers Committee. I want to, my notes went away. Oh well, that's okay. I don't need them. Thank you. A couple of announcements. First of all, I'm thrilled that Dr. Wagner from Seattle has been appointed the working group vice chair. So he's helping me out with this working group. And I also want to make sure that everybody knows that anyone is welcome to our sarcoma working group meetings. Specifically today, we have a working group meeting. Moving around down here. Immediately following this, one floor up in the Picasso room, small room, it says working group members only, but that's okay. You can come. If you need the virtual link, just email me or Katrina. I'm sure we can hook you up. We would like lots of participation. Our membership really kind of increased after the spring meeting, and so I'd love to see that continue. All right, so when we formed in October of 2020, we had two goals, one of which was to really champion and collaborate with other NCTN groups on sarcoma concepts, and then also, of course, to develop our own SWOG sarcoma concepts. And we've had 4 meetings since just my last update in the spring. One thing that became extremely clear over the past year or so is that no one within the NCTN has any idea who the other sarcoma people are, and we didn't even know if there were other committees or working groups. So we have been really actively reaching out and figuring out who's who, and even just coming up with this chart of who's who within the NCTN is a step forward, and we're actually all getting together at CTOS, the International Sarcoma Annual Meeting, next month to really start to broaden our NCTN collaborations within sarcoma. So there are, if you could actually make the slide a little bit bigger, because I can't see that one. I'm sorry, I'm so needy. There are 3 open NCTN sarcoma trials. The first is, I can't see that well, the 2031, which is thoracotomy versus VATS for osteosarcoma metastases. That is championed through the SWOG Surgery Committee. Important study that is maybe not all that, there's not a fancy new drug, but a super important question that needs to be answered. So if you have any colleagues treating osteosarcoma patients, please consider the COG trial. The Alliance trial, randomized phase 2 trial for advanced angiosarcoma. The paclitaxel naive arm is still open. It's a randomized arm between paclitaxel versus paclitaxel plus nivolumab. That is nearing completion for enrollment, but is still open. And Andy Livingston is our SWOG champion. And then ARST 2031 is a phase 3 randomized trial for newly diagnosed metastatic alveolar and embryonal rhabdo, championed by Mingwei Pan, and that is open to patients up to the age of 50. So again, please consider these NCTN studies that are open. There are 2 NCTN sarcoma studies that will be opening soon, one of which is STRAS-2, coming to the US from where it's been open in Europe for a while now, through ECOG, who is bringing it to the NCTN network, and championed by myself and Dr. Mammon through this working group. And then the Alliance trial for metastatic uterine leiomyosarcoma will also be opening soon. And when I say opening soon, both of those should truly be open to enrollment within 6 months. And Rusty Robinson is our SWOG champion for that trial. So within our group, of course, one of our major goals was developing sarcoma concepts from SWOG. So this concept, S2208, led by Dr. Wagner from the University of Washington, had a hypothesis that immune checkpoint inhibition with paclitaxel combined will improve the event-free survival over paclitaxel alone in patients with local regional angiosarcoma. So not the advanced metastatic setting, but in patients who had resectable tumors. And this randomized study design, we actually submitted to the NCI right before the spring meeting. And unfortunately, in May, we received the disapproval letter. During today's meeting, we'll really delve into how to move forward, or whether we should move forward with this concept and with revisions. There were several interesting, some very helpful feedback in our disapproval letter. The first of which was that we needed to wait until the Alliance trial that I mentioned that is currently open completed. That is the trial similar as far as approach, but in a different population. And so we do expect early readouts from that trial fairly soon, since enrollment is wrapping up. One of the other major critiques was that the population for this concept was too heterogeneous. Of course, angiosarcoma is a rare tumor. We're talking about any sarcomas can occur anywhere in the body, right? But we would be talking about angiosarcoma that arises in the leg as compared to a post-radiation breast angiosarcoma as opposed to a scalp angiosarcoma. So yes, a heterogeneous population, and we may need to address that. So we are actually today going to delve into that during our working group meeting. We have started thinking about potential revisions and actually likely developing a related but technically new capsule, looking at this neoadjuvant approach, likely changing to a neoadjuvant only approach, since one of the major critiques was that the difference between using neoadjuvant and adjuvant added a lot of confounding issues with kind of evaluating results of the trial. We have another capsule in development led by Dr. Jeremy Harris from UC Irvine, who's here today. And this capsule is looking at short course versus long course radiation, with a hypothesis that short course radiation, meaning 5 fractions, will result in non-inferior local failure compared to standard 25 fraction radiation for the preoperative management of high-risk soft tissue sarcomas. And the idea here is that we really want to decrease treatment time. We want to get patients to surgery sooner. We want to start surveillance sooner. And there has been quite a bit of research on short course radiation, but always in single arm studies, small, often single institution studies. And it is being used widely, but with a variety of different approaches. So short course might mean 15 fractions or 10 fractions or 7 fractions. So this would be a goal of standardizing that and hopefully actually address some important health disparities as well as cost and care coordination with this shorter course. So here's this is Dr. Harris's schema where we are randomizing 1-to-1 for these high-risk patients. Stratification factors, as seen here, will include an upfront declaration of chemotherapy intent because chemotherapy is allowed post-surgery in this design, but not required. And there's a lot of variability in clinical practice with that. This is a large study, so 147 per arm in order to achieve 117 evaluable subjects. And then post-treatment, as I mentioned, is allowable for post-resection treatment with chemotherapy. The primary objective here is to evaluate whether local failure after short course is non-inferior to standard 25 fraction course, with a large number of secondary objectives, including toxicity, which seems to be the major concern among, in addition to local failure, among treating physicians, as well as financial toxicity, global health-related quality of life, pathologic treatment response, surgical outcomes, and survival. Eligibility was on that other slide, but we will be excluding myxoid round cell liposarcoma. It is a small subset, but could kind of mess things up if those weren't balanced between arms. And so the statistics on this are what has really caused a lot of debate and conversation. Dr. Harris will correct me if I say anything wrong here, but I think that's safe to say. So the 2-year historical local failure rate is 11%. With the non-inferiority design, we have settled on allowing a margin of up to 14% above that local failure rate, so up to 25% local failure rate, which would be a hazard ratio of 2.4. And this would, with a one-sided alpha of 10% and 85% power, we would need 234 evaluable patients between the two arms. We expect, based on historical accruals across radiation trials, that we could get 6 to 7 patients per year, which would mean accrual over about 4 years. And Dr. Harris has been very, very, very busy presenting this to a number of groups, sometimes multiple times, sometimes multiple subgroups of groups, and has gotten enthusiastic feedback, although of course there's always controversy but I do it this way. So we will move forward. A couple of other capsules in development that I have mentioned previously. This is an idea put forth by Dr. Pan looking at CDK4/6 inhibition plus immune checkpoint inhibition versus CDK4/6 inhibition alone in patients with advanced liposarcoma. And this is currently on hold. We're awaiting some safety and preliminary efficacy data from a single institution study that's ongoing, and we're collaborating and discussing that with them. Another study led by Dr. Cranmer at Fred Hutch is looking at abemaciclib in combination with radiation for retroperitoneal liposarcomas. And this is currently awaiting safety data from their single institution safety run-in pilot that is should be enrolling soon. So as soon as we get that safety data, we will be moving forward with this capsule development. And that is all I have to present to you all today. We do have the meeting immediately following this. So at 12:30, there's lunch there. So wander on over if you have an interest in caring for sarcoma patients and developing sarcoma trials. We'd love to get your input, and especially from multidisciplinary providers. We more than welcome pathologists, radiation oncologists, surgical oncologists, orthopedic oncologists. Please all join us. We need your input. And our contacts are up there if you need us. Thank you very much. Good. Should I answer questions?
Thank you, Dr. Davis. We have enough time for questions, so if you have any questions, feel free to come up and ask questions. I do have question. So I do think that Dr. Wagner's S2208 is still a great concept, and although it's disapproved, we got great comments, and I think it's worthwhile to revise and resubmit. But I guess pending the Alliance trial data, we should learn from whatever
Yeah.
data comes out from it. But if we I think we should revise and we can discuss as a group. I think one particular comment is the subgroup. I know sarcoma is heterogeneous, but it's a rare type, rare cancer. So it's kind of catch-22 there. But we do know like a UV or radiation associated ones are the ones that respond better. And Dr. Wagner also analyzed the DART cohort, angiosarcoma, and we were trying to also enrich for that population, not the visceral ones. Yeah. So
Yeah,
do
and
you
I
have
think,
any thoughts
well,
on that? Yeah.
I suspect Dr. Wagner will want to jump in because I think we were all a little surprised that the DART cohort for angiosarcoma actually had some really nice responses in non-cutaneous. We all assumed radiation-associated cutaneous, UV-associated angiosarcomas would have a good immune checkpoint response, but there were actually some visceral
Still
that
respond.
responded. And on the other hand, there were some cutaneous and radiation associated that didn't respond. So certainly there's something more that we don't have all of that data. And I think Dr. Wagner is on there.
Yeah, I think he raised.
Yeah, can you hear me?
Perfect.
Okay, great. So, I mean, you essentially answered the question already, Dr. Davis, but I agree exactly with what you said, where there was at least one patient on DART with, I believe it was a liver primary that had tumor reduction, technically didn't have confirmed response. So it didn't formally count as a response on the DART study, but clearly had some benefit. And then more recently, there was another paper from another group that also showed a response that's been published in a patient with a visceral angiosarcoma. So there certainly is some activity. It's probably less likely than the cutaneous or especially scalp or face tumors. And I mean, we designed the original study to account for that with at least hints of activity in all groups. And I think we'll have to try and reach some consensus with further discussion about how best to propose moving forward. I think there's general consensus that the cutaneous tumors tend to be more likely to respond. So that would be one way, and is at least going to be the starting point for the discussion later today. And then in part we're limited by what the feedback was, where we can only do so much.
Yeah, of course, the downside to we would love to have a nice clean trial that's cutaneous only, but then your accrual is tough.
Yes, I totally agree. Maybe we should propose like a stratification factor. We want to look at both groups.
Yeah.
Good. Thank you for that discussion.
Anna will be at our meeting later, so she'll help us out, I hope.
Great.
She's here somewhere.
All right, any other questions from the audience or from the Zoom? All right, thank you.
Thanks.
Thank you, Dr. Davis. All right, so we'll move on to the next speaker. Dr. David Jen will be talking to us about the new approved study, well, it's not new anymore, but ongoing study of S2012, randomized phase 2/3 trial of first-line platinum etoposide with or without atezolizumab in patients with poorly differentiated extrapulmonary small cell neuroendocrine carcinoma. And Dr. David Chen is from University of Washington, Fred Hutch Cancer Research Center.
All right, thank you very much. Good morning, everyone. I think I'm waiting on my slides. All right, perfect. So this is a study that was activated back in December 2021. So I'm here to just provide some updates, and also hopefully we can get more sites to open the study. But this is SWOG 2012. It's a randomized phase 2/3 trial for evaluating first-line platinum etoposide with or without PD-L1 checkpoint inhibition with atezolizumab in extrapulmonary poorly differentiated small cell neuroendocrine carcinomas. So just to give a little background, when we talk about neuroendocrine tumors and neuroendocrine cancers, this is a very heterogeneous disease. Essentially, these are cancers or tumors that come from neuroendocrine cells, so it's our hormone-producing cells. So essentially, these types of cancers can happen anywhere in the body. But clinically, more commonly, where we see these cancers start are often in the GI tract and the lung, which is why these two disease groups often see these cancers. There's a lot of different terminology that we use. And along that lines, I think we've, as we start to understand a little bit more about the biology of neuroendocrine neoplasms, particularly within the GI world, we basically have come up with a new terminology, and this is based on the 2019 WHO pathological classification. So essentially, when we think about neuroendocrine neoplasms, we group them based on their differentiation, i.e. kind of their morphology of their cancer, and then their proliferation indices. In other words, how quickly are the cells actually dividing? So we divide them into well-differentiated neuroendocrine tumors, which tend to be more indolent types of tumors, versus poorly differentiated neuroendocrine carcinomas, or NECs. So when we use the term NET and NEC, we actually refer to two different disease entities, and we'll be focusing more of in the red. And within the poorly differentiated neuroendocrine carcinomas, they're further subdivided based on the shapes of their cells. So they're either small cell or they're large cell. And why this all matters is that they have very different prognosis and response to treatments. So this was a very nice review that when we apply this new criteria for neuroendocrine neoplasms, what you can see here, I can't really point it, but on the graph on the left are survival curves. So on the top is the black survival curve for well-differentiated grade 1, grade 2 neuroendocrine tumors. So in clinic, these are patients who often live many years, sometimes decades, as opposed to, let's say, the red line, which is the poorly differentiated neuroendocrine carcinomas, where these patients have survivals of less than a year. And then the well-differentiated grade 3 neuroendocrine tumors is actually a relatively new category that came in 2019. And it matters because these groups of patients actually have a prognosis somewhere in between. And at the same time, we actually used to treat them like a poorly differentiated neuroendocrine carcinoma, and there's some older studies that still include that subgroup of patients. But what we're learning now is they actually don't respond to platinum etoposide very well. And that has been kind of the movement in terms of an endocrine field, is when we're thinking about trials, exactly what patient population do we want to include, and that's actually going to be relevant to a study amendment that I'll talk about a little bit later. So when we think about poorly differentiated neuroendocrine carcinomas, how common is this? This is a very rare disease, and obviously why it's part of the Rare Cancers Committee here. But for neuroendocrine carcinomas, what I have here, this was a nice review done by Dr. Desari down at MD Anderson, who looked at the SEER database and just looked collectively, specifically at neuroendocrine carcinomas. And so in panel A on the top left, essentially tells you what the disease sites of these are. So the vast majority of them are in the lung. So that's essentially small cell lung cancer or large cell lung cancer. But if we focus on the extrapulmonary, in other words, everything outside of the lung, which is the focus of this study, it's a much smaller proportion. So it's 1 per 100,000 incidents. And of that chunk of the pie, the majority of them are the GI tract, but then we also have a smattering of other disease sites like the GU and also gynecological tracts. On the bottom left is to show you the prevalence of the different histologies. So as I mentioned, we have small cell and we have large cell. Small cell is represented by the orange bars, and what you can see is in all of the disease sites, small cell tends to be more predominant, but in GI, actually, we see a higher prevalence of large cell. And again, that'll be a little bit relevant to the study that I'll chat about later. So what's our current treatment paradigm? Well, for many years, we've actually extrapolated our management for this cancer from small cell lung cancer, just because of the histology being similar. For the longest time, we actually had no prospective studies. All of this was actually based on retrospective case series, and I've listed the largest ones here. In ASCO of GI 2022 this year, we actually had our first randomized study. It wasn't really exciting. It was actually just looking at platinum etoposide versus platinum irinotecan, which is another regimen that many clinicians use. But the take-home point is no matter which study that you look at, the survivals are very poor. So the overall survivals is about a year or less with basically our current treatment paradigm. And this treatment paradigm has not changed for decades now. And so obviously, as we're focusing on what other treatments could we use that might be effective, here we're looking at what about immunotherapy. And so I've summarized here basically when we look at single agent PD-1 or PD-L1 checkpoint inhibition, regardless of what agent that you use in small cell lung cancer, the benefit's relatively low, both from a survival standpoint and also PFS standpoint. And then likewise, for the limited studies of single agent checkpoint inhibitor and extrapulmonary neuroendocrine carcinomas, we similarly see very low response rates and also very low PFS rates. So the question comes is, what about combination treatments? And where this comes from is basically in small cell lung cancer, as many of you know, is that the new standard of care now is chemoimmunotherapy with platinum etoposide and also atezolizumab. This was based on the IMpower 133 study, where they treated untreated extensive stage small cell lung cancer, randomized patients to either induction 4 cycles of atezolizumab and platinum etoposide, and then if they had no disease progression, got maintenance atezolizumab versus the standard of care, which was just induction platinum etoposide 4 cycles alone. And based on that study, there was a noted overall survival benefit. Now, in the bottom left table, you can see the median overall survival benefit was just an absolute improvement of 2 months. But if you look at the survival curves, it's the greater proportion of patients who have longer term overall survival. And so based on this data, the FDA approved atezolizumab in March of 2019. So the question is, can we use this? And I know some people in the community are starting to use this off-label as well too. But I think in the neuroendocrine community, we've actually wonder, is extrapulmonary neuroendocrine carcinomas actually the same disease? So in small cell lung cancer, that's a disease that arises from smoking. And obviously that leads to tumor mutational burden, and that potentially predicts potential response to immunotherapy. But that's not the case for, let's say, GI, which these are often in relatively healthy young patients that come in, don't have a history of smoking. And so we don't know if the biology is the same, nor if the response is the same. Likewise, when we think about other disease sites, so in GI, I often see de novo cases. In other words, it's a patient who just out of the blue develops neuroendocrine carcinoma. But for example, in GU, we might have a prostate patient who develops a typical prostate cancer, gets treated like that, but then ultimately transform into a prostate small cell neuroendocrine carcinoma. And so that transformation contributes to some heterogeneity, which we don't know what the responses are. And then the other thing is I showed you the data where monotherapy checkpoint inhibition has relatively low benefit. And so we have no prospective data about what the role of that maintenance checkpoint inhibitor is. And so based on that, that is actually the foundation for this ongoing study, SWOG-S 2012, which is a randomized phase 2/3 trial. And essentially, this is for all untreated, poorly differentiated extrapulmonary neuroendocrine carcinomas. We are trying to be as broad as possible, given how rare this patient population is. We will, though, understanding that some of these patients have to start treatment quickly, allow up to 1 standard cycle of platinum etoposide. And what you'll notice here is that there's 3 arms instead of 2 arms, what we saw in IMpower 133 for small cell lung cancer. And so the arm that's added here is that red arm, where we're only evaluating chemo induction immunotherapy alone. And then if no disease progression, they go on to observation. And that's trying to answer better the question is, what is the relative role of the maintenance checkpoint inhibitor? And all patients will get 4 cycles of induction therapy, and then up to 1 year on the maintenance or observation phase. And primary endpoint, we're looking at overall survival from the time of randomization, so from the time of starting treatment. And then secondary endpoint, we'll also look at survival from the time of the maintenance observation to get a better understanding of what the role of the maintenance checkpoint inhibitor is. We're also excited that we get to collaborate with several colleagues down at MD Anderson, Drs. Carl Gay and Lauren Byers, who are thoracic oncologists, but they published very nice work at looking at several different transcription factors that could predict potential response to immunotherapy and chemotherapy. And because we only have very limited tissue samples, this was a very nice collaboration that we developed. And so we're hoping that with the study, we'll identify biomarkers that could predict response to treatment. Now, the biggest thing, as you notice on the title, is that it's restricted to small cell histology only. And the reason being was when this trial was developed several years ago, there was another competing ECOG study. It was GI focused. It included patients with well-differentiated grade 3 and large cells. And so the NCI did not want the study to compete with that, so they asked our study to be restricted to small cell. And so as it is, that study has now closed. That data has now been reported already. And so we have the opportunity to broaden our eligibility. And I have been working on a protocol amendment for this. The issue, though, is the NCI on the first round has no concerns about broadening it to small cell and large cell, but then came back with some comments about trying to be a little bit more specific for the GU patient population and only wanting de novo cases, which unfortunately is not a very common clinical presentation for GU patients. So we're actually trying to work with the NCI to be as broad as possible because accrual has been an issue here. We've had 2 patients enrolled on the study. 1 came off the study because wanting treatment locally, and then 1 patient is actually actively receiving treatment, having completed cycle 2, I believe, is on an immunotherapy arm as well too. But we're hoping if we can be as broad as possible, we can really help pick up the accrual here. And I would encourage, if you don't have this open at your site, that with the protocol amendment, hopefully you'll be able to identify patients as well. And so with that, I just want to thank a bunch of people, including the entire study team, as well as everybody within SWOG who is supporting the study. And with that, I'll take any questions.
Thank you, Dr. Jan. Yes, we have enough time for questions. Any questions from the audience or from the Zoom? I can start. Well, I'll start with a comment that I do agree that like a prostate, there's mixed histology and also radiation-induced small cell, and they're very different. And that is one of the reasons why we did create one cohort within DART to address just that prostate radiation-induced small cell cohort there. So we're trying to look impact of radiation, not the radiation, nivo-8B in that subgroup treated with nivo-8B, obviously, in metastatic case. So I do think biology is really different depending on the tissue of origin. So I mean, I think it will be a really good learning trial. So, we were hoping to get different histologies, but I do agree accrual is an issue here, and we as a committee will be fully supportive of making this as comprehensive as possible, and we are happy to talk to GU committee and just to sort out that issue.
Yeah, and I think we have full support from the entire neuroendocrine task force and such. And, part of it is I understand about the heterogeneity, but as part of the study, we actually have a stratification factor of prostate only. Now, granted, we might have a mix of de novo and then also mixed, and obviously that might muddy the waters. But at the same token, too, because of the stratification, we can look at that group as one, and then potentially we're not going to really have a lot of great opportunities to really do a large study like this again. And so I think this would be a great opportunity. Let's just answer the question, right, for all these patients. So,
yeah. This is Dr. Kurzrock. I don't know if you can hear me. Can you hear me?
We can hear you well.
So I think my concern is there a timeline for expanding?
So basically, I'm submitting this week because we're trying to get it by next week, which is the due date. So
yeah, I really want to be supportive of this, and I think the expansion is obviously the way to go. I do know that we're going to come under some pressure for accrual. So I'm transmitting the pressure on me to you.
Oh yeah, no, well, understand, I hear the pressure, Dr. Kurzrock, and the study team is well aware of it. So we're working on it, but we also just want to be cognizant that we want the study running, but we also want the study to make sure that we're accruing correctly, but also answering the questions that we wanted to in the first.
No, we totally agree.
Yep.
Great, thank you. Chris? Yeah.
Yeah, and that's actually where a lot of the comments came. Dr. Burgess, who's our GU disease liaison on this study, he was the one that has been helping a lot in terms of providing references and how do we justify to try to keep these patients onto the study. So, oh yeah, the ring them. Yeah, they're on board too. Yep.
Great. Any more questions?
Yeah, hi, this is Rusty Robinson. I don't know if you can hear me or not, but I was going to ask if there's a GYN liaison for that trial.
Yes, we do. So we have a disease liaison. So basically, if there's any questions as patients are being treated, is Dr. Swisher at our institution. And then Dr. Haider Mahdi is actually our NRG champion. So.
Great, sounds good.
Great. All right, if there's no more questions, we'll move on.
Okay, thank you.
Thank you, Dr. Chen. So the next talk will be my talk. I'll be giving you update on the translational immuno-oncology projects in DART. So, can I have my slides on? Yeah, so as I introduced myself, the vice chair of this committee, I work here in Chicago, Northwestern. I actually saw a couple of patients this morning and going back to see more patients after the meeting. But happy to be here to give you the translational medicine project aspect of our DART trial. So this is my disclosure. Can I actually have the slides without the note, the full slides? Yes, thank you. All right, so we talk about the objective and the background of the whole TM objectives. And we do have academic collaboration with CMAC, and then we have commercial collaboration that's still ongoing. So the whole concept of the trial is to replicate what we've seen in immunogenic tumors such as melanoma or renal cell. We've seen long-term survival benefit with CTLA-4 and PD-1 inhibition. So we have this rare tumor, a total of more than 50 different cohorts. We have unknown genomic immune landscape. We would love to delve into this and make it a rare tumor TCGA. We need obviously more funding for this, but we want to look at response predictors, as well as we later plan to look at the immune-related toxicity predictors, and we want to look at the genomics, transcriptomics, immune cells, and then proteomics, utilizing the tissue and the blood that we have from our samples. So first, this trial started in collaboration with NCI Match. NCI Match also had focus in rare tumors, and they were screening everyone to look for targets. So this is how the samples were processed in NCI Match. Now we have amended our protocol so that we have access to all these samples that were collected through NCI Match. So I would say first 1/3 of our patients were screened through NCI Match and were only enrolled to our DART trial if they screen failed. And this is the translational medicine that was data available from the NCI Match. So we could request residual samples, but we can also data generated from the NCI Match laboratories. So we'll start with the genomic traits. We're hoping that we would analyze genomic stability or instability that we usually is correlated with response to immunotherapy. We're looking at, of course, DNA damage response, gene aberrations, MMR, HRD, POL-D, or we're also looking at germline as well. We do, with the whole exome sequencing, plan to analyze the somatic tumor mutation burden as well, and replicate what we've seen in lung cancers and many other immunogenic tumors. But remember, our trial is many rare tumors. So across different tumor types, this is a correlation reported between the objective response rate from the immunotherapy trials and the median number of coding somatic mutations in different histologies. And as you can see, there's nice positive correlation here. It was first reported in 2017 in New England Journal of Medicine. And not only just the response rate, if you can look at the overall survival, you can see that TMB did correlate well, top 10%, 20%. There was a dose response correlation with the overall survival, and it looks like across different tumor types that did hold true. So hopefully in rare tumors, these are more common tumors they analyzed. We would find something similar or something different. So we do want to look at these patterns across different tumor types. So what are the things that we already know from the trials that were run? So this is the first-line Nivo trial, Checkmate 026. It did fail to show any benefit of using it in all comers. And as you can see, high TMB did separate the progression-free survival in patients getting first-line Nivo in non-small cell lung cancer, but it did fail to show any benefit in separating curve in overall survival. This is the same approach using atezolizumab. Everyone gets atezolizumab monotherapy. They did look at the blood TMB and found that there is nice correlation between the response rate as well as survival. But as you can see, the PF does look like they are separating by blood TMB level, but the overall survival failed to separate. So here, whether you get single agent PD-1 or you get Nivo-Ipi seems to matter in my mind. And single host immune indicator, such as CRP, was the best predictor of overall survival in this group. So I want to emphasize in the end, we are looking at the host factors, looking at different cytokines in our patients as well. And also, that was a long data, but what about bladder cancer data? It looks like TMB does separate overall survival very well, even with the single agent PD-1 and correlated with the response rate as well. So I think the value of TMB really depends on the histology and the regimen that you use. This is the non-small cell lung cancer data. Everyone uses Nivo-Ipi, so now we're going on a combination regimen, and it looks like both PD-L1 and TMB separates the PF curve very nicely, and it looks like in PD-L1 negative group, you look at the response rate, the value of TMB is even greater. And this is the Checkmate 227. This is what led to Nivo-Ipi approval in non-small cell lung cancer. And this is their subgroup of high TMB group. And as you can see that within high TMB, PD-L1 was predictive of better PFS and OS. But you can see that regardless of PD-L1, if you compare Nivo-Ipi versus chemo alone, there seems to be very similar benefit. So this is the PD-L1 positive and negative group, and you can see Nivo-Ipi. You can see whether Nivo-Ipi performed better than Nivo or Nivo chemo option, and the benefit seems to be marginal. They're much better than chemo itself, but is Nivo-Ipi better than Nivo is a question that has to be answered. So here at Checkmate 227, surprisingly, we learned that if you compare Nivo-Ipi frontline versus chemo alone, regardless of PD-L1, regardless of TMB, the experimental arm performed better than the control arm. So TMB is being used currently in clinical practice. So right now we can use still any FDA-approved next-generation sequencing that can calculate TMB. And then 10 mutation per megabase is our current cutoff. This was based on the Keynote 158 trial, which led to FDA approval in June 2020. So this was a very small trial, more like a signal finding trial, 102 patients. And when they looked at TMB high group defined as 10 or above TMB, the response rate was 29%, and is quite durable. So there wasn't no randomization or looking at survival. There's more high unmet need, all solid tumors, really just histology agnostic trial that led to approval. I think this was quite innovative approach, just like the NTRK approach. We are getting a lot of histology agnostic approval from FDA now. So this, I just want to show you that they did include a lot of rare tumors here in Keynote 158 trial. And you can see the small cell lung cancer or cervical cancer had some TMB high group in there. And then depending on the different cohort, you see the blue is a TMB high, and red is the TMB low group. So the lesson is TMB low group, some patients do respond. And when they do respond, regardless of TMB, it seems to be very durable. And then the last graph is the one with different histologies showing the distribution of TMB high and TMB low. So in practice, we do check this to see if pembro is eligible or not. And what we learned from this trial is that tissue TMB had no whatsoever correlation with PDL1, here combined score of the IHC. So this is a very interesting study coming from MSK that they separated the group, tumors into two groups where there seems to be correlation of neoantigen burden and CD8 cell infiltration. So if they correlated, then there seems to be a nice correlation between response and TMB. But if that didn't correlate, then there seems to be no good correlation with TMB and immune response. So this is their data utilizing many different clinical trials, and they showed that it really depends on histology, that some histologies, TMB high did not pan out to better response rate or even better survival. Some actually had worse survival, and they show breast cohort and glioma cohort as an example. Again, they grouped first and the second category cohorts, one with nice immune neoantigen and TMB correlation as a cohort number 1 and cohort 2. As you can see, the response correlation did occur with only group 1, but not with group 2. So the next question is the TMB really important for immunotherapy only? What if we add chemo? That's just, good question to ask. And lung cancer, the carbo-pembro regimen was based on the Keynote 21 and 189. And based on the two trial, they did combined analysis looking at above median, lower median, the exome sequencing TMB. And we learned that really, regardless of TMB, chemoimmunotherapy worked better than chemotherapy alone. So at least the chemo negates the value of TMB. At least we know that. But nice to confirm that we're looking at the nivo-ipi regimen in rare tumors. Now we're asking question in other tumor types, what are we seeing? Small cell lung cancer, well, I'm hoping we get small cell lung cancers or high-grade neuroendocrine tumors. And it looks like the data that we have from small cell shows that response rate and PFS and OS does correlate pretty well with the TMB level, which we haven't seen with non-small cell that much. Here, now we're moving into the genomic traits. So the biomarker of resistance can be extracted from the gene expression profiling. So we have nanostring and other RNA sequencing platform in place with CMAC. So we're very interested in looking at the signatures. So there's been reports out there that there could be a bottleneck mutation such as JAK1/2 or beta microglobin gene mutation. If you have very high TMB or high MSI high or great neoantigen, if you have problem with your interferon gamma machine, then you're not going to have a response. And then we do want to look at the HA class heterogeneity versus homogeneity, because we are looking at that those reports coming out, and also looking at some transcriptomic modeling. Loss of function in mutations in chromatin remodeling gene PBRM1 in renal cell carcinoma is a great example. and also frame shift indel mutations in renal cell carcinoma. They've been all linked with better responses. And I do suspect that the quality of neoantigen is going to be important. So if we can, have develop a way to better assess the neoantigenicity of the mutations within our cohort, that would be great. So we believe frame shift, you're going to have different peptides just because of one frame shift, as opposed to indel. So this is just a study that we looked at in lung cancer, just the presence or absence of frame shift indel in targeted sequencing panel did show nice separation in survival outcome, non-small cell lung cancer patients treated with immunotherapy, and nice correlation with objective response as well. And it does, the frame shift indel frequency and TMB association were looked at. There seems to be good correlation. And then the other genomic traits that we're looking at is the PDL1, the gene term CD274 amplification. Dr. Kurdrak's group have looked at it. It was found across different tumor types, and 0.7% was the average incidence rate. And when you do have it, the objective response rate was as high as 66% with median progression-free survival of 15 months. So we do have this in our DART cohort, and this is the only cohort that does not use nivo-ipi, but single agent nivo. We do have a lot of problem enrolling patients into this cohort because gene amplification, as clear as we've noted in our protocol and letters, it is not IC, it is the gene amplification. A lot of study coordinators have put patients that have high expression of PD-1. So more than half of our patients are not analyzable. But this cohort is still open and accruing, so I do want to encourage people to consider this cohort for your patients. And then germline, we want to look at the hereditary cancer syndrome genes. Most of them are DNA damage response genes, so we want to look at the association between germline and response or refractoriness. Here, definitely MMR will be looked at, and current clinical practice is that pembro, dostarlimab, both are approved for MSI high. Interestingly, both have separate indication for endometrial cancer, MSI high. But their response rate were pretty similar, 40%, 41%. So just going back to the gene signatures, there's been a lot of different gene signatures looked at, first from the melanoma group. IPRES is one example. And then from University of Chicago group, Wnt beta-catenin pathway signature has been proposed, as well as chemokine signatures. HLA transcriptional loss can be looked at. It has been linked with acquired resistance to combination immunotherapy, which could be relevant to our case. So more and more trials are incorporating gene expression profiling as a even companion diagnostic. So this is one example in Power 150, where they looked at T effector cell high signature, and they just looked at whether that group had better response or not. So that was really built in as a co-primary objective. And as you can see here, the T effector high signature group did correlate better with survival in this graph, and that was the bladder cancer, and this is the atezo first line non-squamous non-small cell lung cancer data. Also looking at the similar signature here, and you can see by the signature you can enrich group that will benefit from the immunotherapy containing regimen versus not. So I think this is future, and this, we do want to develop signature in rare tumors or across different tumor populations. And also we want to look into the chromatin remodeling gene as well. And of course, now we want to look at the tissue to better identify the tumor infiltrating lymphocytes. So we have multiplex immunohistochemistry, CyTOF, and we'll be able to analyze the genes, the cells. We definitely have interest in activated CD8 T cells, exhausted T cells, MDSC, Tregs, B cells. There's more data, interesting data coming on these. You'll hear more from Kara, who's here. One way that we are planning to do because we do have H&E slides for all patients enrolled, we want to be able to better quantify TILs and link them into, whether they had good response, or we do have exome and RNA sequencing, so the pathway analysis. So this is what my group have done, linking the TCGA lung cancer data and just classifying them as a hot tumor, cold tumor, and excluded tumor, and linking them to different immune pathways. And this is the recent paper from JCO looking at more than 1,400 patients getting immunotherapy, lung cancer, and this is probably the first paper utilizing AI platform, looking at just H&E slides and separating the PFS and OS nicely with the TIL assessment. And it did also separate nicely with PD-L1 added to it. So they were not correlated, they were orthogonal. So this is the graph, as you can see. TMB high, not TMB, TPS high, PD-L1, and TIL high were the ones that had the best survival outcome. So we were hoping to analyze TIL in our DART cohort as well. I mean, we, with support from BMS, we have the DACO 28-8 IHC. This was the companion IHC monoclonal antibody for nivolumab trial. So we have that done already. So we'll be looking at that. And in nivo-ipi, the data is, it really matters what histology you're talking about. Right side is the melanoma data that the nivo-ipi provides most benefit for PD-L1 low. And PD-L1 is high, then nivo-ipi is as good as nivo. But if you look at the renal cell carcinoma, like in all comers, looks like the PD-L1 does separate curve nicely overall survival for nivo-ipi versus sunitinib. We have a collaborator looking at the mass spec. This is the right side is the nivo-ipi treated melanoma patients. And you can see that the proteomic signature separates the curve really nicely. So we want to be able to look whether remember these proteins are coming from the host liver. These are not really considered tumor factor, but host factor. So they're sometimes CRPs or albumins. There's a lot of proteins coming out from liver as response to having cancer in your body. So the host factor analysis is really important. And germline is only part of it, but I'm hoping that serum proteomic analysis will give an answer to what we are missing from tumor analysis. Obviously, we are looking at neutrophil. We just had that discussion in our CMAC monthly call. Unfortunately, we don't have the neutrophil lymphocyte ratio, but we have ANC and platelets. And I published on NLR too. I mean, it's as you can see, I found the meta-analysis, like so many recent papers, and they all seem to have found really good, nice correlation, not just PFS, but overall survival with any tumor histology, with any regimen, whether it's combination or the single agent immunotherapy. What's interesting is neutropenia relates to better survival, even in chemo patients, not just immunotherapy. So, neutrophil is really immune suppressive, and that's just having negative impact in patients' overall survival, whether they get immunotherapy or chemotherapy. And neutrophilia has worse negative impact in survival as well. So I think it will be worthwhile because we just have the data to look at that in our patients. Platelet, if you have thrombocytosis, that's immune suppressive. So there's data on that as well, so we can look at it. And this is just a nice, just having 450 as a cutoff, 4.5 as a cutoff, just high or low separates survival curve really nicely. This is anyone getting chemotherapy in non-small cell lung cancer data. And this is really nice comprehensive analysis of more than 1,700 patients coming from 16 different cancer types. And they did look at the NLR ratio for all these groups, have found consistent predictive value of predicting worse overall survival in this group. And they all got immune checkpoint inhibitors. And what was interesting is that they did found this nice dose response relationship with TMB, and not just response, but also overall survival. So they weren't correlated at all. Of course, they wouldn't be, but this is nice interaction between the host blood neutrophil and the tumor tissue TMB, and how they can be used more as a composite indicator for response or to therapy or survival. So there's gotta be a bottleneck. How do you combine all this? We just talked about so many things, but it looks like it's not just this Keynote 028 trial, but across different trials, we've always find TMB, PD-L1, or gene expression profile, they do not correlate. They're independent, they're orthogonal. If there's anything you take out from this talk is that they're all different. So the future should be let the platform or the AI figure out the weight of all these, and because they're all weighted independently, we should all factor those in when we want to predict better survival or response to each therapy. So this is TMB and also inflammatory gene signature coming from PD-L1, CD8, LAG3, STAT1, and they used the famous melanoma nivo-ipi trial, checkmate 6.6 and 6.7, and they showed the same thing that I just showed you, that this signature and TMB are independent, but they can be layered as PD-1 and TMB. So the gene expression factor can be layered to separate the overall survival curve very nicely. So one of the lessons I learned is that in TMB low group, PD-L1 matters more when you use the nivo-ipi regimen. We used nivo-ipi regimen in our SWOG lung map trial and learned the same thing. So this trial was nivo-ipi versus nivo, 1-to-1 randomization post chemotherapy. This was now old trial, but we learned that there was no benefit nivo-ipi over nivo in unselected patients, but exploratory subset group analysis showed that there's a potential overall survival benefit of nivo-ipi over nivo in patient with high TMB, low PD-L1. So there's that interaction. This is, I understand, subgroup exploratory analysis, but nice curve that separated happened only in PD-L1 negative group with high TMB and low TMB. And one thing interesting I want to touch briefly on is from this nivo-ipi trial, the largest trial and the longest follow-up of nivo-ipi, that's why I'm bringing this trial back up, is that there is a 4-year follow-up that shows that nivo-ipi had still durable overall response rate, a survival rate of 29% versus chemo alone 18%. And of course, PD-L1 higher group had better response, better survival rates. And then the benefit did pan out in PD-L1 negative group. But then what was really interesting in the immune toxicity, yes, we would like to get into the toxicity issue later, but the data says that regardless of PD-L1, whether your PD-L1's high or not, and most people discontinue therapy because of the treatment-related adverse events, which are immune toxicities. And when they stopped it, they discontinued. And it wasn't resumed, but still, 4-year overall survival rate was 44%, really high, and that was regardless of PD-L1 level. So you can say, immune toxicity development is probably one of the strongest predictor of durable response or survival. So I do think in the future, we have to develop algorithm between all these factors and also understand what is the bottleneck. It's not the aggregate. It's not like the clinical factors, like you have this score 1, 2, 3 and the aggregate. And if you have a bottleneck, a mutation, that there's not going to be response. So what are those? Where are they? I do think it's very important to discuss that. And then the other thing is a heterogeneity, like it's a subclonality. Are these mutations happening subclones or clonal? And that has been shown to correlate with the immunotherapy response as well. So we have pre-treatment fresh biopsy or archived tissue within 6 months. And then we have blood from 3 time points, baseline and the first imaging and progression. This blood translational medicine initiative was added in when we separated with NCI match. So about 2/3 of our patients will have this blood. Before we didn't have it because it was part of the NCI match trial. This is the big schema of PD-L1, immune biomarkers, germline sequencing, proteomic signature, ctDNA sequencing, and tumor NGS. And then later we had CMAC people join with more comprehensive analysis. But the industry collaboration is the Circulogene analyzing the ctDNA and Biodesics analyzing the mass spec proteomics data. So we started with JAX and then NCI took over, and then we've had CMAC come in as a nice pilot project of the first selected immunotherapy trial. So we're very happy that we have CMAC support. And our next talk will be from Dr. Kara Haymaker talking about what she found so far. So these are the assay platforms of CMAC, and the one with the red yellow is the one, tier 1, that we have priority on. And these analysis will be mainly done at MD Anderson, but data analysis will be done at Dana-Farber, and the proteomic O-link will be done at Mount Sinai and so forth. And this is the biomarker plan. As you can see, the assay lab is mostly MD Anderson, but you have the Mount Sinai, O-link, and CyTOF, Stanford. So this, the whole data will actually go to the Cancer Immunologic Data Commons, CIDC, at Dana-Farber. So we're excited that all this, structure built in place. I'm hoping more and more immunotherapy trial from NCTN will be utilizing this platform. And this is really just multi-omics, multi-scale atlas of the immune changes we're going to see in these trials. And we have the CyTOF and other different sequencing, but it's really a matter of how do you prioritize, and with the limited funding, which cohort to come up first. So we decide that we have 3 neuroendocrine tumor cohorts. 2 are non-pancreatic, 1 is pancreatic. So we have that 3 group first prioritized, and then we have groups with at least 2 patients with subjective response and the groups with at least 1 patient. So that's our kind of the schema of prioritization. But again, we do want to look at the whole landscape, the genome and immune landscape of these rare tumors. So we're still sort of trying to understand what funds are available to do this. So the last update is the cohort 22 and 23, and 25 are being analyzed, and Dr. Haymaker will be giving us the updates on what they found so far. And then the next cohort will be the thyroid, metaplastic breast, and angiosarcoma. The clinical data have been either published or presented at major meetings. The frustrating thing is that we don't have samples for every patient enrolled. So we identified 16, 17, 16 patients in these cohorts that are analyzable and stored. And we're working on manuscript on pancreatic neuroendocrine tumor and thyroid, and try to add at least the PD-L1 for this manuscript. And the non-pancreatic cohort data will be presented by Dr. Kara Haymaker. All right, so a lot, I did cover a lot, but thank you so much for the collaboration. I'd like to thank my co-chairs, Dr. Kurdrak, Dr. Patel, and our subgroup chairs, as well as our SWOG leadership operation, BMS, and then CMAC team. Thank you. All right, any questions?
I have a comment. This is Dr. Kurzrock. So that was a beautiful presentation. I just wanted to comment that one of the things that we published recently is that PD-1, which has not gotten a lot of recognition, but PD-1 on TILs may be an important marker. In fact, in our series, it outperformed PD-L1. And there's actually previous publications that before I wrote up this paper, wasn't really aware of. There's a paper in JAMA Oncology previously published. So I think that one of the interesting things that is going to come along is we've really hyper-focused on PD-L1, but there's other markers, PD-1 being one of them, but it's possible that CTLA-4 or VISTA or TIM3, that the tumor uses alternative checkpoints, and that we actually need to know which checkpoint is being used in order to predict response.
Thank you, thank you. I totally agree. PD-1 has been relatively neglected, but I do think definitely we need to take a look at it and look at all the correlation with other immune cells as well as response. Yes, thank you. All right, if there's no more questions, we'll move on to our next speaker. Dr. Kara Haymaker will be giving us updates on the translational correlates of DART from CMAC, the non-pancreatic neuroendocrine cohort. She is the assistant professor and co-PI of the MD Anderson Cancer Center, University of Texas, and the CMAC director and the director of the Orion Core MD Anderson Cancer Center. Thank you.
All right, thank you so much for that kind introduction, and thank you all for your feedback on this talk. I'd like to thank the organizers for the opportunity to present today some of our early findings related to the non-pancreatic neuroendocrine cohorts as a part of the DART study. So I have no conflicts of interest related to this disclosure or to this presentation. And this is a true team science effort. As was mentioned in the previous talk by Dr. Che, this is a pan-CMAC effort to support the exciting findings of the DART study led by SWOG. You can see a number of individuals, so I just wanted to thank everyone first, and especially the amazing study team leads, Dr. Patel, Dr. Che, and Dr. Kurzrock. So what are we doing to actually try to understand what's happening both in the tumor microenvironment as well as systemically within our patients with these rare diseases? So the way this is structured is we are looking at gene expression profiling using nanostring as well as various genomic signatures, including tumor mutation burden through whole exome sequencing. In addition to that, to understand what's really happening at the cellular level within the tumor microenvironment, we are looking at the classical PD-L1 IHC, but we're also utilizing multiplex immunofluorescence staining to understand different cell types that can be present within the microenvironment, and beyond that, how those cells are interacting with each other. What is the spatial relationship of those cells relative to each other, and then does that associate with a positive outcome in our patients? Now, these assays are done at baseline only, as was mentioned by Dr. Che. These are pre-treatment biopsies. But in addition to that, what we do have are longitudinal assessments in the blood. So utilizing circulome analysis, we're looking at cytokines, chemokines, and other soluble proteins using the Olink platform at the Mount Sinai CMAC. And here we're able to look at a large number of soluble factors in circulation that could be changing over time. And we are looking at the comparison between baseline, baseline, cycle 2, week 9, and then at time of progression. In addition to that, we're trying to understand what are the changes that are induced systemically and utilizing CyTOF-based approaches with the Stanford CMAC support here. Now, we're trying to look at changes in T-cell memory, especially given the role of IPI in driving T-cell priming. We're trying to understand different changes in activation of these cells relative to patient outcome, and then also looking for different potential suppressive mechanisms that could be induced on treatment and whether or not those could provide insights into actionable targets that could be applied in the future. So the initial biomarker analysis, as was previously discussed, is across 6 different cohorts that are a part of the DART study. And today I'm going to focus on 2 cohorts, cohort 23 and cohort 52. These are the neuroendocrine carcinomas. These are non-pancreatic neuroendocrine carcinomas. Cohort 52 is selectively focused on the high-grade neuroendocrine carcinomas. This is an expansion cohort based upon the findings from cohort 23, where a positive outcome was found in high-grade tumors as opposed to low-grade tumors. So what we've been able to analyze across these 2 cohorts, you can see here in the upset plots, we have on the left all patients for analysis. You can see we've been able to look at a total of 44 patients. We did have 1 patient drop out, so we have only 43 where we had ability to look at the tumor. And you can see across all of the different assays that we've utilized so far, the various combinations. And then we have 24 patients where we had both baseline and on treatment cells available for CyTOF analysis. And this is combining the 2 cohorts that I just mentioned. Now, based upon those 44 patients that we can analyze, this is looking at the overall survival on the left as well as progression-free survival on the right. And so you can see we have a median survival of 8.9, and you can see that we have a median PFS of 3.6, again, specifically focusing on the patients that we're analyzing to compare the translational biomarkers. So, if we first focus on what we're learning from our gene expression profiling efforts at baseline, I'm going to talk to you about different cell scoring that we're identifying in the nanostring data set. So what was really interesting to find, we've been utilizing nanostring in a few different ways. Of course, we're looking at pathway analysis, and that is currently underway, but we're also utilizing this to identify different cell types that can be present within the tumor microenvironment prior to therapy and that association with patient outcome. So what you can see here on the left is a B-cell scoring using the timer algorithm that is applied to the nanostring data set. What we were very excited to find is that, in fact, patients with a poorer outcome, either progressive disease, which is shown by others, or stable disease in the middle, really didn't have much of a B-cell score. But when you look at the responder population, you can see that we do have a strong enrichment of B-cells prior to therapy in patients with a subsequent good outcome. In addition to that, you can also see that we have a myeloid dendritic cell signature that is not as clearly restricted to patients with a positive outcome, but is kind of spread more in a stair-step fashion based upon outcome. But overall, what we do find is more dendritic cells as well as more B cells at baseline is associated with improved outcome. When we take the B-cell signature and we apply that to looking at patients based upon overall survival and progression-free survival, you can see the Kaplan-Meier curves here. We see that when you have a greater than median of B-cell scoring, you have a much better overall survival and progression-free survival. On the other hand, neutrophils are associated with a poor outcome. When we have a less than median scoring of neutrophils present within the tumor microenvironment, so specific to the TME, not in circulation, these patients do better, versus if you have a higher than median scoring, this is associated with a worse outcome, both in the context of overall survival and progression-free survival. Now, when we look at the different cell types that we can identify using multiplex immunohistochemistry, as well as understanding the associations with PD-L1, that's what I'm going to touch on now within the tumor microenvironment. What we found is that PD-L1 expression does not associate with patient outcome in these two cohorts. In fact, we had very few cases that were PD-L1 positive, and we had to set a PD-L1 cutoff at 1% to detect any. And you can see one example, though, in B here in this figure, showing that when PD-L1 is present, we can identify it, but it has no association in C or D with overall survival or progression-free survival. Going back to the understanding the immune landscape using multiplex immunofluorescence, here we're applying two different panels to the tumor microenvironment staining. We're looking at the PD-1, PD-L1 axis, and this allows us to understand the TIL presence and their expression of PD-1, as well as their association with macrophages and tumor cells that might be PD-L1 positive or negative in the TME. In addition to that, we're trying to understand activation as well as cytotoxicity and suppressive cell types with panel 2. So thinking about T regulatory cells, thinking about cytotoxicity profiles with granzyme B, memory states with CD45RO, and this panel is really focused on the TIL population, either in a bulk TIL population or in the cytotoxic T cell specific subset. When we look across the tumor microenvironment in these patients, what we can identify, this is now stratified based upon detection of these cell types, with the highest population shown on the right and then decreasing in the intensity assessed. What we see is that, like I mentioned with the IHC, PD-L1 expression is generally low, but when it is present, it's found on the tumor cells as compared to the myeloid cells within the microenvironment. We see that the tumor-infiltrating lymphocyte population is comprised of both cytotoxic subsets as well as T regulatory cell subsets, and we can see that the TIL and the cytotoxic T cells do express PD-1. In addition to that, we see that memory cells are found both within the bulk population as well as within the cytotoxic population, but are a bit more enriched in the bulk population, so suggesting that these might be CD4 in origin. Now, when we separate this based upon location, so looking either in the tumor microenvironment at the top or looking in the stroma to understand if these cells might be kind of captured around the periphery of the tumor, what we can see is that overall the immune infiltrate is slightly higher in the stromal compartment, but very much also present within the tumor compartment itself. And we also see that PD-1 positive TIL are present both within the tumor and the stromal regions. Now, what was very interesting for us to understand, because again, we have clinical associations based upon grade, and again, that's why cohort 52 exists. But when we look at the immune infiltration, we see that it actually does not cluster by grade. We have this very interesting type of association where within both high-grade tumors, we can see that there's a more very immunologically cold, even just absent immune populations. And these patients actually still do respond. You can see that by response criteria based upon stable disease inclusion or the absence of stable disease with response 2 and 3. But you can also see responses based upon those that have a more immunologically hot tumor. So this is very interesting. And when the genomic data, as it evolves, it's going to be interesting to see if tumor mutational burden might be a stratification here that we can assess. We also see that when we do an unsupervised clustering, we don't show us any type of a correlation with response grade or demographics in the context of the overall immune infiltrate. We don't see that more T cells present within the microenvironment associate with patient outcome, and we don't see that this associates with grade. Now, when we transition and look at the changes that we can assess longitudinally, so here now looking at in the circulome in the blood to understand if we're getting immune activation, does this differ based upon cohort, et cetera? What I'm going to talk to you about now is the findings from our cytokine, chemokine, and soluble factors. The CyTOF data will update on shortly in another conversation. What we find in A, this is now looking across hundreds of different types of soluble factors that we can assess in circulation. What we're finding is that we have an induction of soluble PD-1 in circulation relative to baseline. You can see this with the blue circle with the 2 dots indicating significance. Looking at a clustering dendrogram, you can see that we have some interesting features that are happening relative to baseline, where we have this kind of an immune mobilization happening. We're getting soluble factors associated with PD-1. We're getting other factors associated with T cell and B cell activation and mobilization features. And you can see that this in C is going up at baseline relative to cycle 2, week 9, irrespective of grade. So this is happening across the high-grade restricted cohort as well as across the PAN cohort. Now, when we look at how this relates to response, we see some other interesting things happening. We see some interesting findings relative to an absence of response, where IL-8, for example, is coming up in patients that have a worse outcome, but we see other signs of immune activation associated with a positive outcome. In A, you can see that interferon gamma, for example, is coming up in our responding patients. This is broken down relative to response and disease progression in B and C based upon those individual markers. But overall, what this tells us is that we are getting immune mobilization across both cohorts, but we're getting a very type of specific activation relative to response, and we can detect this at cycle 2, week 9 in circulation. We can also look at associations, either utilizing a univariate or multivariate approaches with progression-free survival and overall survival. And what we're seeing is that there's this interesting feature with soluble LAMP3 present at baseline. And this really positively associates with an improved outcome in terms of overall survival as well as progression-free survival. You can see this in D and E. And that's important because that tells us that we might have an activated dendritic cell population at baseline. And if you recall, what I showed you earlier is that in the tumor microenvironment, we also have B cells and a dendritic cell presence that is related. So this is very suggestive to us that there could be a tertiary lymphoid structure association at baseline that really could be a positive biomarker for us relative to patient outcome. So what have we learned and where are we going? So in terms of the tissue, the tumor tissue profiling, what we find is that the presence of B cells and myeloid dendritic cells at baseline within the tumor microenvironment really correlates with improved outcome. Our next step is to look for different types of tertiary lymphoid structure signatures within our nanostring data set to see if we can further refine this finding. We do see a very low level of PD-L1 expression within the tumor microenvironment, both utilizing a chromogenic IHC as well as a multiplex immunofluorescence-based approach. And we also see that grade does not appear to drive immune infiltration by T cells. We do, however, see that responses can be seen in immunologically cold tumors as well as moderately infiltrated tumors in this cohort. And we're trying to understand how these cells interacting with each other utilizing spatial profiling approaches might actually refine our understanding of how these cells could be cross-talking and how that might then associate with outcome. And our circulome analysis is really showing a strong association between response and immune mobilization and highlighting very specific biomarkers that can be associated with the presence of an active tertiary lymphoid structure such as DC-LAMP. The genomics approaches relative to different types of mutations like the JAK-STAT mutation that was previously discussed, as well as HLA expression and TMB is underway, and so is the CyTOF analysis to link these soluble factors with these cellular changes and really focusing on understanding immunologic memory as well as activation and suppression states. So with that, I'd like to thank you all for your time, attention, and again, thank you for the organizers for the opportunity to present on behalf of the CMAC network and this fantastic collaboration with SWOG and the DART team. So thank you so much.
Thank you, Dr. Haymaker. That was a great presentation. Any questions from the audience or from the Zoom?
Yeah, excellent presentation. Very interesting.
Thank you.
I have a couple questions. I know, when the initial response rates were reported from the DART, a lung primary, high rate non-lung primary. So my first question is, do you have any data breaking down lung versus non-lung? And then the second is that very interesting that you noted that grade doesn't really affect duration, which is a little bit different.
I know. Sure. Great questions. So to your first question, we do not see an effect based upon the primary. It is hard though, because this is a little bit of a restricted subsetting. And so we only have a smattering of patients across different primaries. So we don't see that the lung primary has more of the, all the immunologically hot or moderately infiltrated subsetting. It's just one of the caveats of what was available. Relative to what I kind of am understanding, I think there are two features at play. I think it's quite interesting that in the high-grade context, we do see that associates with outcome, and we do see that B cells and these myeloid dendritic cells do track with response. So that does suggest that that level of infiltrate could be associated with grade, but the overall T cell infiltrate is not necessarily associated with grade. And we almost have an even split between these completely almost T cell negative populations that have a good positive outcome, and then those that have T cells that also have a good outcome. So frankly, to me, that suggests that IPI is a key player here, because this is going to drive immunologic priming and ideally bring in then activated T cells that can then participate and interact with those B cells and dendritic cells that were there to start with, and thereby driving the subsequent patient outcome. Now, that is one thing that we are actively exploring within the CyTOF data set, because we really want to understand if we are getting a priming event happening, and that's the way we can assess that. And then also trying to see if those T cells are exhibiting other types of immunosuppressive features that could then result in recurrence. Thank you.
Great, thank you. I have a question.
Yes.
So you talked about the importance of tertiary lymphoid structure. Yeah, do you think this is something that's unique to neuroendocrine cohort, or does the data suggest the role of the B cell and the tertiary lymphoid structure in other tumor types?
It definitely is important in other tumor types. We see this in immunologically hot tumors as well, in terms of having an association with a positive subsequent outcome, or even when we're able to assess longitudinally the presence of this coming into an effect when you have a positive outcome. So it is definitely not specific to neuroendocrine cohorts.
So in cold tumors,
Yes.
the presence of this structure.
Oh, and immunologically cold tumors?
Yes.
That is a little more challenging. So the data, that is going to be something we will be really trying to understand across the DART study, because I think that is going to be something that will be a bit unique. I don't know that that has been well characterized in a very immunologically cold tumor context. It's been much more characterized in melanoma, non-small cell lung cancer, more of these active MSI high tumors in a pan context.
Right.
Yeah.
Yeah, I think that's what makes this DART,
Yes.
TM so exciting. Yeah.
Absolutely agree.
Great discoveries coming.
Yes. Yes. More to come.
Any other questions before we wrap up?
Okay. Thank you all so much.
Thank you. All right, our next speaker will be Dr. Patel. Dr. Patel is our co-chair for our DART trial. He's from the UC San Diego Moores Comprehensive Cancer Center from San Diego. He will be talking to us on the DART clinical trial updates. Welcome.
Great, thank you. And thank you for the opportunity to discuss some of the clinical aspects of the study after really a nice discussion around some of the translational objectives. One of the goals behind this study at a higher level was to disprove the notion that rare tumor studies cannot be conducted. And I'll go through some of that data. But then more importantly, many of the tumor types that are being investigated actually don't have any genomic or immunologic information available for further research. And so the idea that we would create a TCGA of rare tumors with clinical response information available for researchers to allow for the next generation of rare tumor studies is really one of the key higher level objectives of our trial. And so to start with, the genesis of DART, S1609, really came from the unmet need in rare cancers. And while individually cancers are rare, in aggregate, rare tumors represent about 1/4 of the cancer burden worldwide. And potentially more importantly, rare cancers are actually more frequent in younger patients. Actually, under the age of 40, quote unquote, rare tumors are much more frequent. And so this not only is an unmet need in terms of the type of research that historically has been done, but really, unfortunately, burdens our younger patients. And an additional difficulty historically with these types of clinical trials is the heterogeneity of the primary tumor sites. We all live in cancer centers that are divided by the organ of origin for tumor and for expertise, which has a lot of advantages. But for rare tumor studies that cross multiple organ types, this can often represent difficulty. And I think there's no better example of that than neuroendocrine tumors, which can arise from the GI tract, the gynecologic tract, the lung, from the lungs, and other places. Anywhere you have neuroendocrine type cells, which is pretty much anywhere in the body, you could have a neuroendocrine tumor. And this is actually something that happens with sarcomas, for example, and other tumor types. And so the idea of generating a study to answer the question that at this time, back in 2014, 2015, we were constantly being asked by our patients with rare tumors, will immunotherapy work for me, was the genesis for this study. And so to really start with, in 2017, we started with 33 studies as listed here. Since 2021 with 53 different rare tumor cohorts, as you can see listed here. And the idea behind the use of immunotherapy in rare tumors is not a new one to SWOG by any means. In fact, the use of pembrolizumab in Merkel cell carcinoma and nivolumab in anal cancer is work done by fellow SWOG investigators that led to pivotal approvals of anti-PD-1 directed strategies in rare cancers. And then the next question is, what would be the immunotherapeutic strategy that one would want to use in a signal finding platform study? And the idea that we may not have a second chance to investigate many of these rare tumors led us to want to use a combinatorial immune approach to test more philosophically the benefit from combined immune checkpoint blockade. And so we've had data that the combination of CTLA-4 and PD-1 inhibitor here, ipilimumab and nivolumab, may have higher response rates and benefit in a subset of patients. And we saw some translational data that may, after the fact, explain this phenomenon. And so S629 DART is the first and only NCI-funded rare tumor immunotherapy basket study. We currently actually have 53 open cohorts. The primary objective is objective response rate. It's a Simon two-stage design. It's a signal finding study, and with imaging assessments at effectively every 2 months. As mentioned, we utilized a combinatorial immune checkpoint blockade approach here, using ipilimumab 1 milligram per kilogram every 6 weeks continuously. This is the regimen that's used in thoracic oncology for non-small cell lung cancer. And so this is slightly different than what has been utilized in melanoma or renal cell carcinoma, and this until progression, toxicity, or withdrawal of consent. And as of September, when these slides were baked, we had 795 accruals across 53 cohorts. So really going to the heart of the criticism that rare tumor immunotherapy trials aren't feasible, the accrual in this study really shows the unmet need, and as mentioned earlier, really an unmet need in our younger patients. And so I'm going to summarize some of the data that's been published and seen before. Unfortunately, some of the data I wanted to present today is embargoed for upcoming conference presentations, but hope to be able to show that data when we're able to at an upcoming meeting, maybe in the spring. And so for neuroendocrine neoplasms, these are heterogeneous groups of rare tumors that can occur throughout the body. And they're as heterogeneous in terms of their primary organ site of origin as they are in terms of their differentiation status as well as their grade. In fact, high-grade neuroendocrine carcinoma is not dissimilar from small cell lung carcinoma, which is a very aggressive tumor. And the heterogeneity in pathologic classification makes these tumors very complex. So we have gastrointestinal neuroendocrine tumors, then there's pancreatic neuroendocrine tumors, which of course reside in the GI tract, but have their own classification system. That publication is in process. And then lung and thymic tumors, which have their own classification system. So heterogeneity, not only along the disease organ of origin, but also its pathologic classification. And so the neuroendocrine cohort overall, the initial one I'm going to talk about, really has a history with a prior response rate about 5% with anti-PD-1 monotherapy in high-grade neuroendocrine carcinoma amongst 32 patients, which did not include pancreatic neuroendocrine carcinoma because of its unique histopathologic characteristics and antecedent treatments. About half of our patients had high-grade carcinoma and half had a GI primary. 2 was the median number of prior lines of therapy. We see here for neuroendocrine cancers a wide range distribution ranging from age 36 to 81 with a median of 60. ECOG formostats typically was 1, and really a variety of primary tumor types that we see here. Mentioned half are high grade, and anywhere from 0 to 7 prior lines of therapy, 2 being the most common. And so we looked at the initial waterfall plot. We could not discern responders from non-responders, at least based on the organ of origin of the tumor. However, when we looked at grade, those patients with tumor shrinkage tended to have high grade, though in a bimodal fashion, there are patients with high-grade tumors with very aggressive disease that did not respond to immune checkpoint blockade, really indicating the importance of the translational work and the biomarker work we're doing to separate these two very distinct groups amongst high-grade neuroendocrine cancers to both answer the question, A, amongst high-grade tumor types, what's different compared to low intermediate grade tumor types amongst the same cell of origin, even organ of origin? But B, why is there this bimodal distribution even amongst high-grade tumor types, amongst those that respond and do not? Is it some of the work that we alluded to earlier with B cells, dendritic cells, tertiary lymphoid structures? Are there other genomic correlates of response? This is some of the work we're very keen on looking into, and some of actually the very initial work, not only in Cmax for DART, but actually throughout the entire Cmax mechanism through the NCI across the cooperative groups. When we look for the duration of response by grade, we see one of the salient characteristics of immune checkpoint blockade, that those patients that respond to immunotherapy often have deep durable responses. So many of these high-grade patients who had 2 prior lines of therapy, their expected survival with third-line chemotherapy is on the order of less than 6 months. And so to see patients over a year with continued and durable responses, and some of these patients are actually patients I see in clinic here at UC San Diego, is really gratifying given the quality of response and quality of life they have. And so when we look at the overall efficacy, the objective response rate is 44% independent of primary site, regardless of those pulmonary, GI, and a clinical benefit rate that recapitulates this. Much of the clinical benefit in the lower grade histologies may frankly be related to the underlying slower growth kinetic in that group, given the lack of responses. 6-month median PFS, 31%, which in a highly pretreated population is really unprecedented, and a median overall survival 11 months, which is really driven by those patients with responses. One question with the use of combinatorial immune checkpoint blockade is the development of severe immune-related adverse events. This is one of the reasons we went with the lower continuous dose of ipilimumab, 1 milligram per kilogram every 6 weeks continuously. And we see here that high-grade immune-related adverse events, grade 3 or grade 4, for liver dysfunction approach 10% in terms of high-grade. High-grade colitis, 6.2%, but these patients, after steroid treatment, were able to continue on study. We had no case of pneumonitis and no grade 5 lethal toxicities, fortunately. So limitations of the work in this cohort, we had no resources, unfortunately, for central pathology review. And so we relied on local pathology reports, mitotic rate and Ki-67. The post-translational studies, which the nice talk we heard from Dr. Haymaker and Dr. Chai before, are ongoing, and we're eager to be able to share these results, not only to complete the story from DART, but to also drive the next generation of rare tumor studies, potentially, with a TCGA of rare tumors, or at least an immune hypothesis on those patients that may benefit versus not. And also local adjudication of organ of origin. There's no central imaging review resourcing available here. And then the high-grade versus low-grade analysis was not pre-specified in this cohort. The formal high-grade analysis is, in fact, is what I'm going to present subsequently. It's a single-arm study, non-randomized, 32 patients. And so let's talk about this dedicated high-grade neuroendocrine cohort study. We had 19 patients with high-grade neuroendocrine neoplasms. All were microsatellite stable, separate, distinct cohort of patients from the prior cohort that I just presented. The objective response rate was 26%, with a 6-month PFS rate very similar of 32%, duration response 10 months and ongoing, particularly in those patients with response, which I'll show momentarily. And at a high level, no grade 5 toxicities here. Rash was actually the most common high-level adverse event that we saw. ALT, AST elevation was second. These typically were lower grade. We didn't have any higher grade events in our cohort here. And as mentioned, our confirmed partial response rate was 26%. When we look at the waterfall plot, again, the organ of origin did not seem to determine therapeutic response or lack thereof, as these patients were all high grade. And we had patients with either proliferative pancreatic neuroendocrine tumor, colon, high-grade neuroendocrine cancer, lung, rectal, esophageal, vulvar. So regardless of the primary site of origin, potential response or stable disease. And so S1609 is the first NCI-funded rare tumor immunotherapy basket study, 53 rare tumor studies, over 765 accruals, 44% objective response rate. We were able to accrue this cohort, this is the confirmatory cohort, within 2 months with 21 accruals. So showing the dynamic nature of DART in addressing these questions in rare tumors, with a 26% response rate with durable responses, suggesting a subset that may benefit Of course, unfortunately, patients with high grade also could have rapid progression due to immune resistance. And we're looking at this from a translational standpoint actively, as you've seen. Next, from our colleague, Dr. Wagner, we had an angiosarcoma cohort. This is a very interesting disease that has a cutaneous, more UV-mediated signature, as well as a non-cutaneous signature that's often associated with breast tumors, often with radiation. And we see here that patients with cutaneous disease are bimodal. They either have a really nice response, especially if it's on the face or scalp where most of these occur, or progression. And so understanding the biomarker story here, yet again, in terms of response versus non-response and non-cutaneous breast tumors versus others are some of the bimodal analyses that we're doing from a translational standpoint. And then metaplastic breast cancer, these are metastatic patients, but patients with metaplastic breast cancer, so more similar from a teratoma, I guess, standpoint in terms of an analogy. We see here, this is a tumor type in which almost half of patients have PD-L1 overexpression, and these tend to be low TMB microsatellite stable tumors. And we see here a patient with a really nice response to the combination of immune checkpoint blockade with a near closing of their breast wound. And you see by PET CT in the bottom right-hand corner, the disease in the right lung that mostly resolves actually after their initial treatment regimen. This is a study led by our colleagues at Dr. Adams. So as we've seen with immune checkpoint blockade and DART, there's a bimodal distribution. There are patients that respond versus do not. It did not matter the subhistology of these patients with metaplastic breast cancer, whether it was undifferentiated, whether this was spindle cell. And so this is another cohort, yet again, that shows the story of a subgroup of elite responders, patients, though with similar histologic characteristics, not responding, indicating that there may be relevant immunobiology that our CMAX collaboration may help elucidate. And so I won't belabor this point because this was the immediate presentation preceding ours, but these are the types of analyses that are currently underway within the CMAX multiomics approach. And this is a collaboration across, really nationally across multiple institutions, as shown here. And these are some of the assays, as mentioned earlier, that we're currently keen on looking at to try to discern not only the relevant biologic characteristics of rare tumors, many of which are not available in TCGA, but also the relevant immunosensitizing characteristics from immune checkpoint blockade that may help us develop new biomarkers to understand this disease, even in more common tumor types. These are some of the spatial analyses that Dr. Haymaker referred to, as shown here. And so to summarize, we have an efficacy signal for ipilimumab and nivolumab in high-grade neuroendocrine carcinomas, angiosarcoma, metaplastic breast cancer to date. However, this is in a subset of patients who derive elite benefit. There are patients with similar histopathologic characteristics that do not derive benefit, and understanding these salient immune sensitizing biologic factors is key. We have multiple cohorts that remain for accrual if folks have the study open and have patients either in the thoracic realm, so sarcomatoid bronchialveolar carcinoma, in the GU space with spindle cell carcinoma, in the gynecologic space with gestational trophoblastic disease, small cell carcinoma, the ovary hypercalcemic type, or PD-L1 amplification, which is an NGS-based genomic assay, not a PD-L1 protein-based IHC assay. I just want to make that clear because this has been an area of some confusion. We have a nivolumab only alone arm. And I think more broadly, clinical trials in rare tumors are not only feasible, but I believe they're warranted. We're open to over 800 sites throughout the country. 2/3 of these patients are treated in the community setting, really showing the burden not only of younger patients with rare cancers, but really in the community for these patients, with a high accrual rate over the past 3 years, and even a high accrual rate within our confirmatory cohorts. And so with that, I'd like to thank my co-chairs as well as SWOG, CTEP, the NCI, and our CMAX collaborators amongst the multitude of collaborators we have listed here. And I'm happy, and most of all, for the patients and their caregivers, and I'm happy to take any questions if we have time.
Thank you, Dr. Patel. We're happy to take any questions if you have any. So Dr. Patel, so what are the new data that's coming out on upcoming scientific meetings so we could be, expecting them?
Yeah, great question. So the pancreatic neuroendocrine cohort, we should have some data very soon, and then of course shortly thereafter should be available, I believe at AACR. And then for SITC, we'll be presenting some of the data from the gestational trophoblastic disease cohort, for example. And so, we hope to get these out as soon as are able, and are eager to integrate some of the translational data into these presentations, given that this really is a bench to bedside story and back.
Yes, great, thank you. We have a question from the audience. Maybe you have to come up to the microphone so that Dr. Patel can hear. Yeah, we have a microphone at the back.
Hi, I'm Takia Trong from Kaiser Permanente in Northern California. I was wondering, the cohorts have been evolving. Is there a way to advertise better what is open or new? Because I was recently surprised by the PD-L1 amplification cohort. I didn't know that that was there, and there's also very specific genomic testing required to log into it. So I just feel, this study could do much better if there was a better way to know what was open at any time.
Yeah, thanks for the feedback and thanks for the great question. And one of the points, and correct me if I'm wrong, I believe in Kaiser, Strata is the platform that's utilized. And if I recall, Strata doesn't directly assess PD-L1 as part of its primer set as far as assay. It may indirectly do so, I believe, looking at JAK2. And so I think you summarize three of the points very nicely. One is, what can we do to communicate these open cohorts better? And that's something we can follow up on as a team. Two is, though, if the assay is not looking for PD-L1 amplification genomically, then how do we go about ensuring that we're looking for these patients? Where other cell-free testing, for example, can often pick up the amplification, which is often on the 9p chromosome. And so thank you for the feedback, and I think it's something we'll take back at in our next meeting, try to discuss some opportunities to better communicate these open cohorts.
Thank you. We have comment from the Zoom chat box. I don't know, Dr. Patel, if you can see it, but
yeah.
If there's a
yeah, so great points.
Cohort,
oh, good, sorry.
Yeah, wondering about dual checkpoint for chondrosarcomas. If you have any?
Yeah, great question by Dr. Victor. So there are two directives from the NCI related to DART, and one was at the time which DART was launched, I believe as the SARC-38 study, I may be mistaken, was going on federally simultaneously. And so we actually specifically could not have the majority of sarcomas included. And then more currently, the idea that 53 is the cap from the NCI on the number of cohorts that we can have. And thank you in the chat. There is a website that shows the most up-to-date accrual numbers. We have this publicly available so investigators can see if cohorts are open or closed. And maybe, I don't know if we can screen share that or maybe put it in the minutes afterwards for an email, but it's swogstat.org/accrual/DART has always the latest accrual. In fact, it's the website we use to adjudicate slots. And so thanks for mentioning that, Dr. Victor.
Yeah, thank you. One more from the audience.
Yeah, just wondering why the neuroendocrine cohort so robustly accrued on DART and we're having trouble on 2012. Do we have ideas on why that is?
Yeah, so I think S2012 is restricted to small cell only. On this trial, basically anybody who has a Ki-67 of 20% or greater would be enrolled on this trial, right? So it would be the well-differentiated grade 3s, the small cell, large cell. So I'm hoping that once we have the amendment that S2012 will pick up. So.
Yeah, I had a comment about that as well. So I agree that a little bit of expansion would help, but I think all the accrual on DART in any one cohort benefited from the presence of other cohorts. In other words, at its peak, DART was approved, I think, at 999 sites. So if you only had one cohort, you wouldn't get all of those sites. But once you have all those different cohorts, it's really an attractive study across the country. So expanding the other trial, I think, will go a long way.
Great, thank you. Thank you for all your comments. I think we'll move on to next session in respect of time. So our last speaker for our committee meeting would be Dr. Amit Ahluwalia. He is from Miami Cancer Institute, and he is our leader for the CNS working group, be giving us the updates from the CNS working group.
Thank you so much. So I know I'm between you and the lunch, so I'll try to make up some time. So the CNS working group, I'm going to present 4 trials where we are endorsing trials from other cooperative groups who've been, obviously have had a longer history of work compared to SWOG. And then I'll present 2 concepts that our working group is moving forward. So this is the Alliance trial, and the first 2 concepts are actually in brain metastases. That's the focus of our working group, is to support both brain metastases as well as primary brain tumors. So this is an Alliance study that is led by Paul Brown. It's a phase 3 concept of post-surgical single fraction stereotactic radiosurgery compared to fractionated stereotactic radiosurgery for resected metastatic brain disease. We all do know that after, surgical resection of brain metastases is done commonly. We do know that post-SRS is standard of care, showing that compared to control arm, there's improvement in outcomes, and it's better than post-whole brain radiation. However, the local controls with single fraction SRS are suboptimal, often because the cavity is fairly large after surgery. And so hence this trial that Dr. Paul Brown is actually leading, which has been endorsed here by SWOG, and Dr. Chad Rustovan is spearheading this effort, is looking at resected brain metastases where brain met is more than 2 centimeters. If smaller than that, then we probably think single fraction SRS is pretty good. But when it gets to be larger brain mets, there we think fractionated radiosurgery may be a better approach. So this is actually going to look at that. There is a number of stratification factors that you can see, looking for IO as well as targeted therapies, because the outcomes are different in those patients. And we're also looking at the resection cavity diameters, whether it's less than 3 centimeters or greater than 3 centimeters, because there's data out there that local control with single fraction SRS is pretty good for tumors less than 2 centimeters, drops off pretty steeply for others. Next trial is the NRG. So the first trial was through the Alliance Cooperative Group. The second trial is through the NRG mechanism, and this is NRG BN009. Again, this is now a phase 3 trial of salvage SRS plus hippocampal avoidant whole brain radiation for first and second distant brain metastases relapse after upfront SRS or radiosurgery with brain metastases, which has a velocity of more than 4 mets per year. And how do we define brain mets? You can see that it's the total number of new brain metastases since initial radiosurgery, followed by total time interval in terms of years or a fraction of a year since initial SRS. So when you look at what's really the treatment for brain metastases, a lot of it is local control. Now, obviously, in recent years, we've had a lot of targeted therapies and even immunotherapies, which may work for small brain metastases. Immunotherapies don't work very well for large brain metastases, which tend to be symptomatic, requiring steroids. So, local radiosurgery is still fairly used for this. But we do know that there is a lot of failure with radiosurgery. So the question now is that the field has shown that hippocampal avoidant whole brain radiation is better than the whole brain radiation. So question is, can you compare a group of patients who have a higher degree of brain velocity, means they'll have more than 4 new brain mets in the year after, at first or second distant relapse? Because what happens in brain metastases, if you do focus radiation to a particular lesion, you can always have a new lesion which may come up. So here they're trying to randomize, again, there are a number of stratification factors that you can see, but they're trying to randomize looking at radiosurgery plus hippocampal avoidant whole brain radiation at 30 grays. And they're also using as memantine. There's data out there that if you use memantine, you can actually decrease the neurocognitive outcomes. Because the biggest challenge with using whole brain radiation in the past is we know that the control's better, but it comes at the cost of neurocognitive decline of the patients. So for that, we are trying to avoid hippocampal area because which is involved with neurocognition. We also know that memantine can help mitigate that. And then this will be compared to stereotactic radiosurgery because there's retrospective data out there that the patients who have a higher brain velocity may benefit from a combination approach. So this trial is actually testing it. So if you have patients, I think we'll definitely appreciate it. The enrollment's been pretty, not as robust through the NRG mechanism. So they're trying to see if we can support that through the intercooperative group mechanism. Next, I'm going to move on to a trial that we're endorsing. This is the NRG BN007 study. Obviously, we spent the bulk of time in the conference today talking about the story and success story of ipilimumab and nivolumab through the DART mechanism here. Obviously, we do realize that glioblastoma is one of those tumor types which has not had much of any success stories in the last, frankly, almost 2 decades. The last therapy we got approved was temozolomide, which doesn't work in 2/3 of our patients. And so this is a study led through NRG where it's looking at ipilimumab and nivolumab, comparing that to temozolomide in MGMT unmethylated patients. Here, the benefit of temozolomide is actually 21 days. So we give our patients 9 months of therapy for a 21-day benefit. So this is a study that is comparing in this patient population, which is around 60 to 65% of glioblastomas is actually unmethylated. So that means they have a repairing mechanism that will repair the deficiency which is brought up by alkylating agents or radiation. Now, we do know that when there was a phase 3 trial where it compared radiation plus temozolomide to radiation and nivolumab, and unfortunately, that was negative. There was no benefit of progression-free survival or overall survival, but this is looking at the combinatorial approach now of anti-PD-1 and anti-CTLA-4, and we're trying to see if we can get some additional benefit. So there's a phase 2 component and a phase 3 component. The phase 2 component is actually enrolled now, and so we are evaluating whether the phase 3 component will check on. And this is a trial now. The first trial was from NRG. This is a second trial. Now this is from the alliance mechanism. Again, very similar story. In fact, we worked pretty hard here to see if we could get a glioblastoma, somatically hypermutated recurrent glioblastoma cohort in DART, and we did not get our approval because of this study, which was going through the alliance mechanism. This is again looking at combination of ipilimumab and nivolumab. It's a fairly small study here. TMB is defined as 20 mutations per megabase on Foundation 1 testing. And this is looking at patients who have glioblastoma, which is IDH wild type or mutant. It's in first and second recurrence. And it's a fairly small study. Stage 1 is going to be 18 patients with Nivo-Ipi. Even if we get 1 or greater response, it'll kick off to stage 2, which is going to be 14 patients. Moving on to what we are working on as a CNS working group right now, we're trying to see if we can promote trials out of the SWOG mechanism to the Rare Tumor Committee with Dr. Kurzrock's support. So this is a phase 2 study of etolizumab and tocilizumab now with radiotherapy in patients with newly diagnosed MGMT unmethylated glioblastoma. So essentially, as I had told you, this is the cohort which doesn't get much benefit from temozolomide. There's only a 21-day benefit. And essentially, there is data out there showing that anti-IL-6 approach with monoclonal antibody blockade leads to survival in genetically engineered orthotopic GBM murine mouse models. And you can see the green curves looking really nice compared to controls. And we have seen that this happens through reduction of the CD68 myeloid cell infiltration, and there's an increase in CD8 T cell infiltration as a result of using anti-IL-6. Then the question is, can we combine anti-IL-6 and anti-PD-1 to have a more synergistic benefit? And there is data that in mouse models, this approach of combinatorial, as you can see in the nice green curve, looks much better than either IL-6 approach that is better than the control or anti-PD-1 approach. Now, we do know the anti-PD-1 approaches have unfortunately failed in glioblastomas. So the question is, can we use combinatorial approaches as we've seen mentioned today earlier in other tumors? So this is a phase 2 newly diagnosed glioblastoma. Patients will be tested for MGMT. If they are unmethylated, they can go on this trial, and I'll present a sister trial that we are doing, which is going to be for methylated. So when we look at our patients for MGMT expression, they're typically either unmethylated or methylated. So unmethylated patients will go in. It's a pretty common eligibility criteria. The debate we are having is, should we do a phase 2 study single arm, which we can get through CTEP rather than the brain malignancy steering committee. So it's a little bit of an easy pass. And you can see that we are shooting for 1-year overall survival, which is still around 50% in this patient population. They do typically quite poorly. Unfortunately, unmethylated MGMT patients with glioblastoma are only alive around 13 to 14 months. So it's a really dismal outcome group. So the question here is, can we increase the 1-year overall survival from 50% to 70%, for which we need 37 patients with 80% power. And we think we'll be able to enroll in 12 to 18 months. So now the companion study will be TRC102, is it a base excision repair inhibitor, and temozolomide in patients with first-line GBM. And so basically when we use temozolomide, which is an alkylating agent, most of the damage occurs through formation of O6-methylguanine, which is repaired by MGMT. That's the marker I've been talking about. But there are also 7-methylguanine adducts and 3-methyladenine DNA adducts, which are actually removed by base excision repair pathway. And the TRC102 is a drug that was invented by Stan Gerson, the center director of the Case Comprehensive Cancer Center. I had the privilege of working with him when I was there. And we showed that in xenograft models, use of TRC102 was associated with improved outcomes in orthotopic xenografts in combination with temozolomide. So here you see if someone has MGMT, they can have a single hit with MGMT, and if you give them a base excision inhibitor, you can hit a double hit. So it's a double hit hypothesis, and I'll show you some data which actually looks quite promising. So what we did was we ran a study out of the Adult Brain Tumor Consortium, which was one of the federally supported cooperative groups led out of Johns Hopkins. I was the PI of this study. So we looked at patients who had progressed on temozolomide and radiation in first recurrence of glioblastoma. Can we use a combination of temozolomide and TRC102 based on the work that I'd shown you in the orthotopic xenograft models that we had? And our bar was quite high. It was to show a response rate of 30%. So people who've treated patients with glioblastoma, our typical response rates with any therapy is 5% or less. So, we don't get a lot of responses, unfortunately. So it's a really high bar set by CTEP. And what the study showed was, we had a 2-stage design. In stage 1, we did not meet our, endpoints. But there were 2 patients who actually I had the privilege of taking care myself, who did really well. And their progression-free survival was 18 months and 30 months. Now, they were not responders, but progression-free survival in recurrent glioblastoma is actually 2 months. That's the time to next scan. Okay, there are studies which have shown this is actually 6 weeks. If you do 2 cycles of nivolumab and get a scan, they're progressing. It's really, really sad group. So what we found out was when we divided them now to MGMT methylated patients and unmethylated, those who got a combination of TMZ and TRC102 and who were methylated, the median survival, obviously small group of small numbers because 19 patients in total, median survival is like 30.2 months. Now, obviously wide confidence intervals, 9.5 months, right? But what we are seeing appears fairly promising. What we did was we also had DNA and we ran genomic profiling as well as transcriptome. And we looked at that the 2 patients that I had privilege of treating actually had a DNA damage response pathway signature, which actually predicted that these people could get better. And there was a 3rd patient that I again took care of, and that patient progressed right before the 6th month. Because we get scans every 56 days, but calendar years are 2 months, so it's a few days short. So he didn't meet the criteria, and he had a borderline signature. So we had 7 patients that I could get transcriptome on because I had an IRB, and these people were treated at Cleveland Clinic, although they were part of the ABTC collaborative. So on the basis of these 2 patients who did really well and had pretty nice overall survival, we are proposing this phase 1/2 study now of TRC102 in patients with newly diagnosed MGMT promoter methylated glioblastoma, so using the double hit. So these are patients who we do know that they do well with temozolomide. Temozolomide has a 6-month overall survival benefit in these patients compared to unmethylated, where it's only 21 days. So here we will try to see, can we do better with TRC102 in addition to temozolomide. So these are the 2 proposals which are going to go forward. We are working with our statisticians to see if we can push them through, because we definitely, the one thing we do know for glioblastoma patients, if you look at the NCCN guidelines, treatment on a clinical trial is actually even higher than treatment on standard of care because our patients do quite poorly. And everyone who's treated a glioblastoma patient knows that patients want nothing more than a clinical trial. So this is what is happening through the CNS working group. Thank you again for the opportunity to present. Happy to take any questions.
Thank you, Dr. Ahluwalia. This was a great presentation. Any questions from the audience or from the group, from the Zoom? I have a question. So I know some trials are only looking at unmethylated group, which have poor prognosis, very dismal, like you described. Do you think they're enriched because they're high unmet need or for immunotherapy purpose? Is there more like immunological rationale that these should be looked at?
I mean, we have the concept of hot tumors and cold tumors, and glioblastoma, unfortunately, is a really cold tumor. And then on top, the microenvironment's really immunosuppressive, right? We know that because there is data out there that these patients, even before we treat them with radiation, have really low CD4 counts. And there was actually a paper which showed that if you have a lower CD4 count, even with our traditional treatment options, they actually do worse. There's a survival benefit in patients who have a higher CD4 count. So it was like the neutrophil story that you were trying to show, the NLR ratios, right? It's just what your body is responding. And on top, the other challenge for us is really that, in glioblastoma, we tend to use a fair amount of steroids. So I think that's why we're trying to go upfront, because we tried most of our trials in recurrent setting. And I think the sad part is in recurrent glioblastoma, there is no therapy till date that has even shown a single-day survival benefit. Okay, we actually got bevacizumab approved on the basis of a negative trial. Okay, so we have that dubious distinction, unfortunately. So what I would say is we have models, but our models may not replicate what truly happens with the microenvironment, because as good as our models are, they're never good enough to replicate what's going on in the microenvironment. And the microenvironment is really immunosuppressive. So what we are trying to do, honestly, is trying to see, as you can see with these trials of anti-CTLA-4 approaches, anti-PD-1 approaches now, is can we get something which is better than the anti-PD-1 approaches? The anti-PD-1 approaches, there were 3 trials, Checkmate 143, Checkmate 498, and Checkmate 548. So one was in recurrent glioblastoma, all comers. One was newly diagnosed glioblastoma in unmethylated setting, newly diagnosed glioblastoma even in methylated setting. No benefit of any progression-free survival or overall survival with anti-PD-1. So that story is unfortunately dead. What we are hoping now is the next cadre is, can the combinatorial approaches maybe give us some benefit in a select group of patients? And I think what will be key is, can we profile these patients to see can there be a benefit, right? So we have a top-down approach or a bottom-up approach, and we're trying to collect, and obviously through your work, which was talked about by Dr. Himaker, was like we're trying to see, can we collect enough correlates to figure out, can we identify a subset of glioblastoma that is going to do better? I mean, I don't know if we'll be able to move the needle for the entire community, but can we do it for at least for a select group? So that's where some of the successes are coming in GBM, which obviously are not our trials, but we are seeing some benefit in gene fusion patients, for example, just to go on a side tangent. So I'm just trying to, so none of us has a good biomarker, and we talk about not having enough good biomarkers in other cancers. I think glioblastoma is even worse, because when we looked at the PDL1 expression, actually in our Checkmate 143 trial, it was actually ill worse. So patients who had a higher PDL expression were doing better with bevacizumab compared to nivolumab. So I think it's just a different tumor. And even in our some of the early trials we've done with higher tumor mutation burden, we've actually seen worse outcomes with anti-PD-1 use. There was a Nature paper actually outlining that. So I'm hoping that in the Alliance trial, we may see a iota of hint of benefit, but these are really challenging tumors to treat.
Yeah, that's really great. So yeah, I mean, based on what Dr. Haymaker showed us, cold tumors with the addition of IPI, hopefully will bring in a lot of TILs, T cells, and build in tertiary strictures. And I mean, we were focusing on post radiation. These groups have more than usually 20 TMB, so perfect niche. Nivo IPI, I guess we have to wait till the Alliance trial shows any result and learn from it, but I think we might have a niche with addition of IPI, yes.
We thought, we had hoped DART would do it, and had we done it through DART, I think we would have had, fair amount of enrollment by now, but, again, but we are supporting the Alliance trial, so we'll see what the results are.
Right, just last question. I think the TRC is a great concept, TOSI is a great concept. Any unique, correlation with the IL-6 targeting in glioblastoma, or have you seen similar strategy pan out in other tumors?
No, actually, so this is pretty specific to glioblastoma. Some of it just is building on the UPenn experience. So there is a trial actually going on through NRG mechanism BN00010, so 10, which is actually looking at re-radiation, IL-6 and anti-PD-1 story. So they are again going after recurrent glioblastoma, which I think is a very difficult tumor type. I mean, I think a lot of patients by then are on steroids, they've had alkylating agents, and they've had really poor, lymphocyte counts. So I think it's a difficult, so we as a group are deciding to go more after newly diagnosed glioblastoma. That's where honestly, where we have seen benefit. And I think like in dismal tumors, you got to, like anything in cancer, you got to get your best approach up front.
Great.
Thank you so much.
Thank you. So I think our time is up. We'll be concluding the session. Is there any comments from the audience or questions or any comments from Dr. Kurzrock before we wrap up?
No other comments. Thank you so much for helping out, Dr. Chai, and chairing this. And I think it was a lot of great talks, so a lot of exciting things going on.
Thank you. Thank you. Yes, we are still very excited about the ongoing trials and the discoveries we're making. Thank you for attending and thank you for supporting our committee. Thank you. We'll conclude.